Good evening. How is everybody tonight? Warm day here today. Everybody's saying hello. Hello, some of you I saw earlier today, so hello again. It's like we haven't even left each other. I am doing wonderful. Doing great. Good, everybody's doing great. I'm going to show my little screen here. We have a ton of muscles to go through today, but I also need to finish this little slide for you, right? So, because I slightly remember Denise saying she didn't finish this slide here. Am I recalling this correctly? Yeah. See, my memory is pretty good for all I got going on up there. All right. So I'm still waiting for some more people to come in. We talked about caffeine. Yeah, caffeine is some people's friends. It keeps some people going. They're not okay without it. I like a good cup of coffee too, but surprisingly enough, I drink decaf. So, yeah, I drink decaf tea and decaf coffee. So it has a slight amount of caffeine, but not as much as the rest. Drinking coffee right now, that's good. I happen to be drinking water with Ulta, which is an electrolyte to help me stay hydrated so I can stay awake and good for all of you. So, yeah. All right. Well, anyways, so she left off at, does caffeine bother me? It does now. I used to be like a severe caffeineaholic. I used to drink like a pot of coffee a day when I worked in nursing, and I worked a 6:30 a.m. shift. Yeah, I used to drink about a pot of coffee a day, right? And when I got pregnant with my first kid, who is now 13, I stopped caffeine, but then after a while, I went back to it. And then my kids are 6 years apart. And then with my 7-year-old, my now 7-year-old, when I got pregnant with her, I stopped caffeine yet again. And I really haven't gone back to it. Once in a great while, I have caffeine, but it gives me the jitters. And if I go to Starbucks, I just get the regular thing with the decaf, and it's got enough sugar in it to make me go crazy. So I just need the sugar and not the caffeine. So, yeah. So I try to stay away from, I try to stay away from the fully leaded caffeinated stuff. If I'm dying, I'll go for a half calf, but then I don't sleep at night. So it's a a double-edged sword. Sometimes I'll just sniff, like sniff the grounds, and that's enough for me. I'm like, oh, that's good. That's good. Right. So, yeah. Anyways, so angina. Angina is something, it's a discomfort in the chest that you can get. It happens, so you get a discomfort in the chest or you get shortness of breath. What happens is the heart muscle isn't receiving enough oxygenated rich blood, and that makes that pain in your chest or the shortening of the breath. So that's angina. Yeah, that's funny. And then we have a thrombosis. A thrombosis is basically a blood clot, a coagulation of the blood, and it is not moving. Okay, it has coagulated, it is where it is, it's stagnant, it's not moving, it is a blood clot, it is still. Okay, and I'm making that specific. Okay, so that's a thrombosis. So it is not moving. Okay, but an embolus can also be a blood clot, but it is moving. An embolus is a moving clot, blood clot. It could also be an air bubble or a fat deposit. So all of those things can be an embolus, but they are moving through the arteries and the veins, and they can get lodged or displaced, and they can move through and go into your heart or your lungs or even your brain. And all of those situations would not be a really good thing to happen. Okay, so the thrombosis is a better idea because it's not moving, but an embolus moves. So that's the difference. Okay, so on your FYIs that she didn't get to finish, that's those two. But I want to get into the structure because we have a lot of structure to go through today. Hello, everybody who just checked in. Sorry, the dog is in here with me, so you will hear snoring. So heads up, it's not me, the dog. All right, so where is my, let's see, let's take this one off. And let's open this up. Let's go to my F drive. Move this over. Let's go to structure. Keep forgetting to do this. Sorry, guys. Open. Diaphragm. So that is our first one in our structure is the diaphragm. And that's going to be page 160 in your illustrated Essentials of Skeletal Anatomy book, the blue book. So make sure you have that. I'll give you a second to get that out and get out your list so you can write down your notes. Everybody good? Ready to go? Do I know which page in the green book? Oh, I don't. In the green book, it's 154. Thank you. Awesome. So diaphragm. Our diaphragm. So our diaphragm. So in our book, it says it looks like a clover. I kind of think it looks like a mushroom top. But to each his own, right? So our diaphragm divides the thoracic cavity from the abdominal cavity. So it is up on our ribs. Remember, it comes through and it attaches to the pericardium of the heart. So it's on our trunk there. Oh, that's all it's going to give us. Okay. So what you need to know is it inserts on itself. So the insertion is the central tendon of the diaphragm. So it says it right here. The central tendon. So that's your insertion. That's your eye. And you need to know that it divides the thoracic cavity. Ooh. From the abdominal B cavity. Okay, so those are the things you need to know. It divides the thoracic cavity from the abdominal cavity. And its insertion is the central tendon of the diaphragm. So it inserts on itself. So in your little red box, it says the diaphragm separates the thoracic cavity from the abdominal cavity. So I just wrote it a little bit different. You don't need to know the origin. You just need to know the insertion and that it divides this. If that's not an action, what I wrote. Okay, so for this muscle, you just need to know the insertion and that it divides the thoracic cavity from the abdominal cavity. And Crystal, I see your message and I can do that on the break. Okay, so. All right, did everybody have a chance to write that down? Perfect, just a minute, okay. And let me know when you got it. Correct. There's no action. There's no action. There's no origin, just the insertion and that it divides the thoracic cavity from the abdominal cavity. All right. I'm going to erase this. And I'm going to hop into here. Go into here. So this is our favorite little show here, Muscle Premium. Okay, just making sure you guys can see what I see. So this is the diaphragm. So the diaphragm helps us in breathing, right? So that's showing you the diaphragm. So when you look up, this is looking up from the ground at the diaphragm. And you see it has a couple little holes in it, and that's for our, you know, our esophagus and, you know, our stomach, you know, all that stuff to come through, because our stomach's going to start right here, and then, you know, everything else that's not in the rib cage is here. It's going to come through. Yeah, it seals off the top from the bottom. And this one shows you rib elevation, so it's basically the same thing. Oops. Tip this guy. But you can see it's on all of the ribs all the way around up to your xiphoid process and back around, and then a little bit on the spine. And if I tip him towards us, so you can see that's the top of the balloon or the mushroom shape. So it's a very cool muscle. So it's contracting as we exhale. It gets big, and then exhale. So cool. And I have a muscle I have a, what you call it? No. Brain. I have a video. Our favorite guy from the 70s. All right. Diaphragm. Here comes the video. So before we go to the video, if you have audio or any problems, check your audio button in your thing. Try that. If it doesn't work, log out and then back in.
The diaphragm is the primary muscle of respiration and is unique in both its design and function. Its broad umbrella-like shape separates the upper and lower thoracic cavities, and the diaphragm's muscle fibers attach to the inner surface of the ribs and the lumbar vertebrae and converge at a central tendon. Although only a small portion of the diaphragm is accessible, the muscle's effect on the thorax and breathing is easily felt.
So let's access a little bit of the diaphragm. My partner's in a supine position, and I've got the knees bolstered just to soften up some of the superficial abdominal tissue. And what I'm going to do is just set my thumbs right along the bottom edge of the rib cage. And so just right in there. And I'm not going to press yet. I'm just going to work with my partner's breath and just ask my partner, just take some nice, slow, deep breaths. Just going to kind of hold my position as he inhales And then as he exhales, I'm going to sink my thumbs slowly a little bit deeper. Thumbs are nice and soft, not pressing or pushing. And when he inhales, what I'm feeling is not so much the fibers of the diaphragm, of course, but really just the pressure of the diaphragm's contractions pushing the abdominal contents into my thumb. And now I've got a good distance right in here underneath the ribs, and I can just feel that diaphragm contract as he inhales and feel it soften and rise as he exhales. Good. So this is just one way you can get your fingers, or thumbs in this case, underneath to access some of the diaphragm. And then I can bring my thumbs out slowly as he exhales. And obviously I can do a very similar thing around on various portions of the rib cage, like so, along this entire path. And I can even use my fingertips if I wanted, not just my thumbs. So to access the diaphragm in a sideline position, I've got my partner's legs bolstered and have asked him to flex his trunk a little bit, again shortening some of that superficial tissue. The great thing about sideline for the diaphragm is that all of the abdominal contents shift down toward the table, which makes it quite a bit easier for your thumbs or your fingers to sink in underneath that edge of the rib cage, right in there. And again, I'm just going to follow his breath like so. And I can shift even down here and access under here in this position. And that's just another way you can access some of the diaphragm from a sideline position.
Okay. Next up is the intercostals. Intercostals are on page 158. 158. And they don't have origin or insertion really either. So what you need to write down, get my other pen for this. They go from, let's see, rib to rib. You need to go, you need to know they go from rib to rib. And you can see here that they go rib to rib. So we have external ones and we have internal ones, but you just need to know that they go from rib to rib. Okay, so like the muscles of the abdominals, they have the 3 layers, and the abdominals, yeah. I would write rib to rib under origin. I would write rib to rib under origin. So like the muscles of the abdominals, which we haven't really talked about yet, and we will, there are multi-layered, right? So that layering of the abdominals comes up and continues into the ribs, and that's why we have multi-layers. So if you notice here, one layer goes this way and the other layer goes this way, or this way, more so this way. So they can go in opposite ways. So it would go crisscross from each other, right? One goes this way, one goes this way. So the outer 2 layers raise and the inner layers lower. So there's no action. So I'm just letting you know that this is what they do. You just need to write this down. Okay. So you know that they lift the ribs up so that we can take a nice big breath and open up and expand our lungs. That's their job, right? That is their job. I'm just giving you a little more information. Yeah, the outer two layers pull, they raise, and the inner layer lowers. So yeah, I guess you could put it as one pulls up and one pulls down. The outer layers would pull up and the inner layers pull down. Okay. You don't need to know that. That's just like fun facts. Okay, everybody ready? Ready to watch our nice fun video on the intercostals? Yes. All right, let's see. Intercostals, here we go.
Better known to carnivores as the meat on spare ribs, the intercostals are the small, slender muscles between the ribs. They're divided into two groups, the external and the internal intercostals. Portions of the intercostals are easily accessible. It is not possible, however, to distinguish the external intercostals from the internal intercostals.
So my partner is side lying on the table, and first of all I can identify, here's that lateral edge of the latissimus dorsi, there's the outline of the pectoralis major, and I can just set my hand here, and there's that xiphoid process, and I can find that bottom edge of the rib cage right there. And if I set my hand in this space, which is again between the latissimus dorsi and the pectoralis major, very nice superficial region of the rib cage. Great place to start exploring the intercostals. And the intercostals are not on the ribs, they're in between them. So I'm just going to find one little space right there. I'll start right there. I'm just going to work my fingers into that tissue. And there's definitely muscle tissue there. As I roll my finger across it. And then I can just move to that space just above. And there's another space where I can feel some of the intercostals. And if I ask my partner to just go ahead and take a nice, slow, deep breath, really fill up the lungs, expanding the rib cage, wow, the ribs really do separate and sort of expand the space between them, and I can really feel those muscles lengthen and shorten. Go ahead and try that again. Wow, those ribs really separate, spreading apart, and then as he exhales, they come back together. Great. One thing I notice also is that the ribs don't come straight across or horizontal across the thorax. They actually come in sort of a turning direction like so. So I'm just going to keep getting my fingers right in that space, and that's where I'm going to be able to feel and isolate some of those intercostals. And finally, we can come even deep to the latissimus dorsi tissue here, some of that deeper tissue on the low back, and I can just work my thumbs and fingers between those structures, and there we can get in between the ribs to feel some of the intercostals. So not only in the front, but the side and the back of the rib cage, you can access the intercostals.
Okay. So, scalenes. Scalenes are page 154. No, I lied. 155. 155 scalenes. 155 scalenes. So rib to rib origin and insertion is the same. Yes. We just need to know rib to rib. So scalenes. So I want everybody to find their clavicle and put their fingers right above their clavicle, right next to their throat. And then take a really sharp, deep, fast breath in like you're scared. Did you feel those muscles pop up? Do it again. Did you feel them? That's your scalenes. Okay, so if you didn't do it before, let's do it again. So put your fingers above your clavicles, right on your throat, and then take a nice sharp breath in like you were just scared by something. That's your scalenes. So you can really feel them. They're easily found. Easily found. Okay, so we have origin and insertions on this one. So your origin is going to be C2 through C7 transverse processes. So on a transverse process, it's going to be, you're going to know it's going to be a deep muscle. It's a deep muscle of the neck. And then it inserts on the first and second rib. So it comes down under the clavicle onto your ribs. And the action is flexion of the neck, lateral flexion of the neck, and raise rib cage during forced inspiration. That's what we did was forced inspiration, that quick breath in. So if you have somebody who has breathing problems and they take shallow breaths, they don't take belly breaths, they breathe up in their neck, maybe they have asthma or what we call COPD, and they breathe up in their neck area versus in their chest or belly breathing. These muscles are going to be extra built because they're picking up the rib cage so the lung can expand. So they're doing all the work so that they can get the breath. And that's why these people who have this breathing problem take short panty breaths, like, that's how they breathe, is like that short breath, because they can't get a full breath in because they breathe through these muscles. And the other little fun thing about our scalenes is you can see right here, the subclavian artery comes through here. And we also have a nerve bundle that comes through here. So when these muscles are really tight, they can pinch on both of this artery and that nerve bundle. The nerve bundle is the brachial plexus, which goes down into your arm. So if you're pinching that nerve bundle, maybe you're having tingling or numbness in your fingers, and that could be why, or in your elbow area. So that can be partly because of this muscle. Okay. Is everybody good with the slide? Okay. Let's see. Where's my neck? Where's my neck stuff? Let's see if I can get a good one on here. So all these rippy guys right here. So all those little ripped guys in the back. Let me turn this guy. All these are scalenes. Right, so it's a group. So we have an anterior, a middle, and a posterior. But you can see them all right there. So they're a little bit deep to sternocleidomastoid, but they're you can fully catch them right here during massage. So if I put this guy back, he's doing a head rotation. Let's see if I have a better one. I don't know. Let's see if I can, no, it's not gonna let me take it out. I don't know why it's not letting me take this. Big old muscle out. There, you can see them all right there. The best picture I can get you guys. So that's the scalenes. And they get pretty ropey, guitar stringy. You'll feel them on people right up in here. And they feel pretty stringy, especially if they walk with their chin forward. So there you go. Scalene. And I do have a video for scalenes. Here it comes.
The three scalene muscles are sandwiched between the sternocleidomastoid and the anterior flap of the trapezius on the anterior lateral side of the neck. The anterior scalene lies partially tucked beneath the SCM, while the middle scalene is slightly larger and lies lateral to the anterior scalene. Both muscle bellies are directly accessible. And the smaller posterior scalene is located between the middle scalene and the levator scapula muscle. The large branches of the brachial plexus and subclavian artery pass through a small gap between the anterior and middle scalenes.
So let's isolate the structures that really pinpoint where the scalenes are located. First, we've got the SCM, then the edge of the trapezius, and then the clavicle. These three form what's known as the posterior triangle of the neck. And if I set my fingers right into that space and ask my partner to take a nice deep breath into the upper lungs, great. And there, underneath my fingers, I feel the strong, ropey muscles of the scalenes. Great, go ahead and relax. So I'm going to keep my fingers here and isolate two of the three bony landmarks that help isolate where the scalenes are. First is going to be the first rib. First rib starts here, passes under the clavicle, like so. And I can set my fingers into this space and feel the surface of the first rib right there. and that's where the anterior and middle scalene are going to attach. Then, if I shift a little more lateral, I'll find the surface of the second rib, and that's where the posterior scalene attaches. Good. The third landmark, or landmarks, will be the TVPs of the cervical vertebrae, which I'm going to find right here on the lateral side of the neck, just underneath the SCM. So I'm just kind of rolling my fingers across that ridge formed by the TVPs. So now let's just see if we can find the anterior scalene. Go ahead and raise your head a little bit. There we can see the edge of the SCM, and I'm going to leave my finger right there. Go ahead and relax. And that there is the anterior scalene belly. Now the SCM runs in this direction, but the anterior scalene is going to go in that direction. And go ahead and take another high, deep breath, and that muscle clearly contracts, and I can follow it as it passes underneath the SCM to attach on the TVPs. Okay, and relax. Now next to the anterior scalene will be the middle scalene. And there I can feel the belly of the middle scalene, and this now is going to head sort of in that direction. And then if I continue one step further, a little deeper into the neck, will be the posterior scalene. And go ahead and take another deep breath. Sure enough, this smaller, probably the smallest of all scalenes, definitely contracts and relax. And it's going to head out in this direction, pretty much straight lateral. Now, how do I know that I haven't overstepped my palpation and gone from the anterior to the middle to the posterior to the next muscle around the neck, which would be the levator scapula? Well, there's a little test we can do to find out. The levator scapula helps elevate the scapula, but the posterior scalene doesn't. So, if I set my fingers on what I believe to be the posterior scalene, right there, and I ask my partner, go ahead and elevate your scapula. There you go, kind of bring your shoulder up toward your ear. Fabulous. This muscle I'm palpating, it's loose, it's relaxed, nothing's happening. And go ahead and relax. So it's not engaged. So that must be the posterior scalene. And just for fun, if I slide a little further posterior and ask my partner to go ahead and raise your scapula, this muscle, the next muscle in line, definitely contracts, and that's your levator scapula. So a little trick to kind of discern exactly which muscle you're on. Go ahead and relax. Finally, we can lengthen the scalenes by laterally flexing the head to the opposite side like so, and we can shorten them by laterally flexing the head to the same side.
Okay, so somebody asked, are the scalene muscles the ones that give you the stiff neck when you sleep the wrong way? Typically, I find that stiff neck when you sleep funky, right, is usually levator scapula or trapezius. Those are the two main ones. But I mean, it could be this one, but this one is really deep. So it's usually the more superficial muscles that get kinked when you sleep funny. So, I mean, it is possible it could be, but the first one that I would look to would be trapezius for that stiff, kinky neck. Rectus abdominis. Rectus abdominis, page 164. 164. Our rectus abdominis is a very interesting muscle. Goes from our pubic symphysis and pubic crest all the way up to our xiphoid process. I think it should have the same pictures on the next page. Okay, so our origin is our pubic symphysis and pubic crest. So that's the very top part here. On the pubis area of our hips, right? Of our pelvis. And then it goes all the way up to the costal cartilages, ribs 5, 6, 7, and the xiphoid process of the sternum. So this muscle goes up. Like that. Okay. And the action is flexion of the trunk. So flexion of the trunk is doing a bow. Okay. Doing a forward bend to touch your toes. That's flexion of the trunk. And compression and support of the abdominal viscera. So our abdominal viscera is anything outside of the rib cage, our intestines, our liver, all that stuff that's right there behind it. So our abdominals have these, you guys all see, our rectus abdominis has all these little sections here. And these are tendons. These are tendinous sections. And this is called the linea alba right here. And these little tendinous sections give us our 6, 8, 12 pack, right? So what happens is our muscle gets bigger and cuts over the tendon and gives us that appearance of that 6 or 8, maybe even 12 pack. It is our most superficial muscle of the abdominals. Okay, everybody done writing this down? Yes, yes, yes. Okay, perfect. He doesn't do a big bow, but he does one enough that you guys can comprehend. That is flexion of the trunk. He's bringing the sternum down towards the hips. And you can see that it says spinal flexion, right? So you could call it either way. But for your test, you want to do flexion of the trunk. And I have an abdominal video. So you get all the abdominals in your video.
The 4 abdominal muscles expand far beyond the stomach region. In fact, they form a muscular girdle that reaches around the sides of the thorax all the way to the thoracolumbar aponeurosis, and superiorly to the middle ribs, and inferiorly to the inguinal ligament. The revered washboard belly is formed by the multiple superficial bellies of the rectus abdominis. Lateral to the rectus abdominis is the external oblique. Unlike the round bellies of the rectus, the external oblique is a broad superficial muscle best palpated at its attachment to the lower ribs. The thin internal oblique fibers are deep and perpendicular to the external oblique fibers and can be difficult to distinguish. And lastly, the transverse abdominis, the deepest muscle of the group, plays a major role in forced exhalation and cannot be specifically palpated.
So let's begin with the rectus abdominis, better known as the six-pack muscle, but in all reality, it's a 10-pack. So what I'm going to ask my partner to do is, just so we can see the muscle engaged, is go ahead and do a little bit of a crunch. So he's going to just flex his torso a little bit, and there we have a great example of the topography of that rectus abdominis here. And while he's just engaged, I'm just going to set my fingers here and really isolate those individual bellies that extend all the way from the rib cage down to that pubic crest. Great, go ahead and relax. So let's just take this to the next step and just isolate some of the landmarks that help really shape where the rectus abdominis is. The first I'm going to find is just that edge of the ribs right here. So above that is going to be this surface of the rib cage, surface of ribs 5, 6, and 7. And there's his xiphoid process just at the bottom of the sternum. So on one end of the rectus, we've got this surface of the bottom portion of the rib cage, and down here we've got the pubic crest. Now, let's just stop here for a second. Chances are you've never palpated your own pubic crest, let alone your partner's, so let's all find it. You, me, and my partner. So first thing we're going to do is just go ahead and locate your navel or your umbilicus right here. And then just progressively work your fingers down inferiorly, and you'll feel flesh and flesh of the belly, and then there, about 6 or 8 inches down, just above the pubic hairline, you'll feel a ridge of bone, and that's your pubic crest. Okay? So now I'm going to try to find it on my partner. Can I locate your pubic crest? Sure. Okay, so ask permission. So there's his umbilicus, and there we just sort of press into the fibers of the rectus, and right about there, there's the ridge of his pubic crest. If you do a little crunch again, great. And there I can really feel the tendon of the rectus abdominis attached right there. Good. Go ahead and relax. And it gives you an idea of how the rectus abdominis sort of tapers as it comes down the abdomen like so. So now that the belly's relaxed, I'm just going to sort of work my fingers into this belly here. And you can even take both sides and gently grasp them and sort of lift them up a little bit. Great. And here is that lateral edge of the rectus, which is where I can feel the rectus abdominis, and on the other side is the external oblique. So speaking of which, let's see if we can find that. So the external oblique is that broad sheet of muscle here on the side of the torso. And we sometimes think that it's like just here. But no, if you really look at it for a moment, and there we can see it, it spans all the way from this edge of the rectus around the side of the torso and all the way back here to the thoracolumbar aponeurosis. And of course, deep to the external oblique is the internal oblique, which there we can see that running in perpendicular direction to the externals. And then of course, deep to those two are the transverse abdominis fibers. So we've got three broad sheets of muscle that really coat and cover this entire side of the abdomen. So if I want to see the external oblique contract, here's what I'm going to do. I'm going to ask my partner to just bring this shoulder toward this hip. Great, so he does a crunch and he kind of rotates, shortening these fibers right here, which are the external obliques. And all of this surface here, you can see where it interdigitates with the serratus anterior right there. And all of those fibers you can really see come all the way down to that iliac crest to here at the edge of the rectus. Good, and relax. Deep to that, we have the internal obliques running again perpendicularly. And so to engage this side of the internal obliques, I'm going to have him bring this shoulder toward this hip. And so all of these fibers shorten and deep to the external obliques, which still contract a little bit for this motion, but deep to those, right in here, we can feel those internal oblique fibers right there. Great, and relax. And then finally, of course, we've got the transverse abdominis deep to those, which is pretty much unpalpable. But if you're grasping some of this tissue on the side of the thorax right here, in between the bottom of the ribs and the iliac crest, you know that you're accessing the transverse abdominis as well. Good. Okay, reality check. Chances are that your partner's not going to have ripped abs like my previous partner. Most people don't. I certainly don't. And the question arises, when the abdomen doesn't give you any visual clues because it's covered with a layer of adipose tissue, how do you locate the abdominal muscles? Well, I'll give you a hint. A little help from your bony landmarks. So let's give it a try. The bony landmarks that really get me in line with the rectus abdominis. Do you remember what they were? That's right. First, I'm going to just find that bottom edge of the rib cage right here. That's not where the rectus attaches, but it's a really good place to start. And I can follow it right up to the xiphoid process. And if I walk laterally a little bit, there's that surface of those 5th, 6th, and 7th ribs right there. Good. So the muscle comes down the front of the abdomen here somewhere and attaches at that pubic crest. So can I palpate your pubic crest?
Yes.
Great. So there's his navel, and I'm just going to work through some of this tissue here, all the way down, and there is that pubic crest. Great. Now, if you go ahead and do a little crunch, great. And just hold it there for a second. Now, we can't see any of those ripped bellies of the rectus abdominis, but if I set my fingers right on this tissue and work through some of the adipose, there I can definitely feel some of those bellies of the rectus. And here, if I come over to the side, I can really sense the edge of that muscle. Good. Go ahead and relax. Good. So even though I couldn't see any of the rectus abdominis like I saw before, I know just by using bony landmarks and a sense of where that muscle is and visualizing it, that's where my rectus is going to be. And then if I come over here to the side, I again can find that bottom edge of the rib cage, knowing that those obliques are going to cover this portion of the ribs here, all of this space between the ribs and that iliac crest. Let me see if I can find that. There's that iliac crest coming around the side of the torso here. And then if I ask my partner, go ahead and try to bring this shoulder toward this hip, great. And all of this tissue, yes, deep to the adipose tissue is definitely engaged. A very nice solid wall of muscle. Good, and relax. And then when he relaxes, I can work my fingers in and deep to this adipose and feel those obliques. So the lesson here is that you don't need to have ripped abs in order to locate the abdominals. You can do it even through adipose tissue and clothing and whatnot.
Yeah, don't need to have ripped abs to work on the abs. Anyways, I think that we need to have a 10-minute break. So it is 7 on the dot. Let's be back at 7:10. See you in 10 minutes. Okay, I'm here. You guys are here. Everybody's here. Perfect. What is on our next agenda here? Oh, quadratus lumborum. It's page 162. 162, quadratus lumborum. So you can see here that this is on the transverse processes, so we know it's going to be a nice deep muscle. Quadratus lumborum. So the origin is the posterior iliac crest. Right, so the posterior iliac crest. And the insertion is the 12th rib and the lumbar vertebrae of 1 through 4 on the transverse processes. Sure. We'll go back up for 1 second. Here you go. You good? You got it? Okay, perfect. Okay. So quad means 4. My pen is the same color, so 1, 2, 3, 4. 4 quad or quadratus. Lumborum is for lumbar vertebrae, and we're in the lumbar vertebrae. So for lumbar, that's what the name means if you break it down. This is a little tricky muscle. So it's deep. So it is under latissimus dorsi. It is under the erectors. It is deep. So it backs up to the iliopsoas. So it's way deep in there. Its action is a lateral flexion of the spine or trunk. So in other words, it hikes your hip up. It's a hip hiker. So what we're telling you is it brings this hip up to that 12th rib. So it also stabilizes this floating rib, this 12th rib. So that's another thing that it helps us out with. Everybody good with this slide? Yes. Okay. Let's see. I'm gonna move stuff so I can see. Let's see if it shows it in here. Okay. Let's see. I don't know why it won't let me get rid of stuff tonight. But there's your quadratus lumborum. So you can see this is your erectors. This is your transverse abdominus. This is your external abdominus. So you can see, and there's your iliopsoas, and it's behind it. So it's way in there. It's way in there. Let's see. Fade. Fade. There you go. So there you go. So lateral flexion of the spine is what the other movement does. We tell you it hikes your hip, so it does. If you bring your hip up to your ribs, it does. It's doing the same action. But if you're doing this action, you know, a lot of us did this little dance as we were a little kid. You put your arm out like you're a little teapot and you're short and stout and you tip yourself over to pour you out. So that is lateral flexion of the spine when you tip over to pour your teapot out. So there you go. All right. And I have a video for this guy. QL, where's the QL? Quadratus lumborum.
Although it would seem to be the deepest muscle of the low back, the quadratus lumborum is, strangely enough, the deepest muscle of the abdomen. Stretching from the posterior ilium to the transverse processes of the lumbar vertebrae and 12th rib, this squat muscle is simply an abdominal muscle located on the posterior surface of the thorax.
So my partner's prone on the table, and I'm going to begin by isolating the 3 bony landmarks that really isolate the location of the quadratus lumborum. The first bony landmark is going to be the 12th rib, which is located at the very bottom of the rib cage, of course. And I can find the surface of the rib cage, and after a while my fingers sink into the flesh of the posterior abdomen, and at the very bottom, if I go back a little bit, the very bottom of the rib cage, there is his 12th rib. And I can follow it medially to where it attaches here at the vertebrae. So first landmark is the 12th rib. Then we've got the posterior iliac crest. And there's his iliac crest, and I can follow it posteriorly to where it ends at the PSIS, that dimple of the low back. And then finally, the third bony landmark, or landmarks, will be the transverse processes of the lumbar vertebrae. So we know the spinous processes are here, and the transverse processes are going to be a good distance further lateral. So I'm going to set my fingers beyond the erector spinae and work my fingers at an angle, and there I can feel the bony ridge of the transverse processes. They're not like individual points, it's more like a ridge. Good. So now we've got the 12th rib, the posterior iliac crest, and the transverse processes. And in that space will be the quadratus lumborum. So let's check it. I'm going to just set my fingers into that space. I'm going to start laterally. And I'm going to ask my partner to go ahead and bring this hip toward this shoulder. Fabulous. And just a very small contraction, I can feel the QL contract. And go ahead and relax. Good. And now with the tissue relaxed, I can really get my finger into this space between the bottom of the rib cage and the top of the pelvis. Now, let's figure out where the erector spinae are in the midst of all this. Go ahead and raise your feet up slightly. Fabulous. And that action shows me where the erector spinae fibers are. And here's that lateral edge. And I know that there's the erectors, and the QL will be further lateral. Go ahead and relax. Good. And so I can avoid the erectors by getting right into this space for the quadratus lumborum. We can also access the quadratus lumborum in a sideline position. I can find that posterior iliac crest, I can find the bottom of the rib cage, and I can set my thumbs right into that space between those landmarks and ask my partner to go ahead and hike your hip just a pinch. There, and there's that edge and contraction of the quadratus lumborum.
Super cool. Super cool. And speak of the erector spinae, they are our next muscles. So it's page 170. 170. You need to know the names of the erectors. You need to know the names and the actions. Those are the two things that you need to know. So the first one is spinalis, which is closest to the spine. And you notice right here that spinalis crosses over the spine right around C7T1 and comes down. And longissimus is going to be in the middle here. That's the big round one that you can see and feel the most. And then we have iliocostalis, costalis, right, for costals, which is another word for the ribs, and ilio for ilium, right? So you know it goes all the way down to the ilium. So iliocostalis, you know it's going to be more on the ribs and more down on the ilium. So some people like to do this and write, I love spine. I love spine. to help you remember. Okay, and the actions are going to be extension and lateral flexion of the spine or trunk. So extension of the spine or lateral extension of the spine or trunk. So we have 3 muscles in our erectors. They each have their own names. An erector for erect, they hold us up straight, right? No origin, no insertion. Nope, you didn't miss it. You need to know their names and the actions. So, everybody have these good? I have a 1 second. No problem. Okay, perfect. All right. He's really having trouble tonight. Extension. So extension of the spine is doing a back bend, right? It's leaning backwards, extending. Extension of the spine. So you can see all those nice muscles right there, and he's coming at us. So extension, leaning backwards. Okay, so now you can see extension. All right. Erector spinae video.
The erector spinae group runs from the sacrum to the occiput, along the posterior aspect of the vertebral column. The erector spinae muscles are like a tall poplar tree with 3 main branches, in this case, the spinalis, longissimus, and iliocostalis. The spinalis is the smallest of the 3 muscles and lies closest to the spine in the lamina groove. The thick longissimus and lateral iliocostalis form a visible mound along the lumbar and thoracic spine. The long tendons of iliocostalis extend laterally beneath the scapula.
So the erector spinae, those broad muscles that run right up the entire spine. Let's see if we can find them. I'm going to begin by asking my partner to just raise his feet a little bit. That's fabulous, right there. Now, the erectors don't obviously raise the feet, but they stabilize the pelvis when I ask him to do this action, and there we can see really fine example of the lower portion of the erector spinae engaging as he does that. And notice when I ask him to relax, they soften and seem to disappear. Now, to engage the upper fibers, I'll ask my partner to just sort of arch his back a little bit. There you go. And there we can see deep to those middle fibers of the trapezius, the upper portion of the erector spinae right there. Great. Go ahead and relax. And they seem to soften and disappear. Great. Now, there's probably only one key bony landmark or landmarks that's going to help really get your hands on the erectors, and that's going to be the spinous processes of the thoracic and lumbar vertebrae. They run, of course, right down the center of the spine, and I can just set my fingers on those like so. If there's any other landmarks, I'd have to say it would be the PSIs, the posterior superior iliac spines, where those dimples are often found in the low back. And then lastly, probably the surface of the sacrum right here, which is where a lot of the erectors attach onto, right onto that tissue, into the thoracolumbar aponeurosis. Good. So what I'm going to do is just set my fingers next to the spinous processes and see if I can work my fingers into those erectors. Now, since I know that they run up the spine, I know that the fiber direction is going to run this way. So I'm going to purposefully roll my fingers across the fibers and really get a sense of their fibers and their density. Really quite large here in the lumbar area. And as I progress superiorly, they become a little broader and a little more tendinous, sort of thinning out a little bit. Here I'm working underneath those lower fibers of the trapezius. Now there's three branches of the erector spinae. The most medial, closest to the spinous processes, will be the smaller branch of the three, which will be the spinalis, right in here, right in that lamina groove. And then if I take it a step further lateral, I'm going to roll across the longissimus fibers. And then the most lateral will be the iliocostalis right out here, which has those tendons that come here almost spreading right underneath the scapula. Great. And finally, let's just check to make sure we're on the muscles we think we're on. If I ask my partner to just raise his feet up a little bit, I want to see if these muscles engage, and they do. Great. Go ahead and relax. Do these fibers run vertically up the spine? Yes, they do. And if I move up into the thoracic area here, beneath the superficial trapezius and then the intermediate rhomboid fibers, deep to those there, I can feel the fibers of the erector spinae. And those are just all ways that you can check to make sure that you're really feeling the erectors down the entire back.
Okay. Transversospinalis. So he called these TVP in the other video, right? And they are going to be on page 171 and 172. and 172. Okay. So I'll let you guys get your whatever you need from this. So this is a group, okay? This is a group. So you can see in this picture that they go from one vertebrae to the other vertebrae, one vertebrae to the other vertebrae. And then on the bigger ones, you can see that they go from here and then they come back to there. So they come from one to another, one to another. So they're really tight in there by the spine. Okay, so there's multiple names. Okay, as you can see, the multifold, the rotators, the semispinalis cervus and thoracics. So these are all the group. So you need to know that there are 5 sets of muscles in the group. In general, the origin insertions are the spinous and transverse processes of the vertebrae. So for origin and insertion, you put spinous and transverse processes of the vertebrae. And then their action is to do extension, lateral flexion, and rotation of the spine or trunk. Okay. They also help stabilize our vertebral column. So if you're looking at your book on 171, you'll see it has 2 groups, and then on 172, it has the other 3 groups. But this is what you need to know. You need to know it's 5 sets of muscles in the group. And the general or origin and insertion is spinous and transverse processes of the vertebrae. The action is extension, lateral flexion, and rotation of the spine or trunk. Okay. My little program does not show these very well, so I'm not going to do the muscle premium on these, but I do have a trail guide video. So is everybody good? Okay.
The multifidi and rotatories are part of the transversospinalis muscle group. They are deep to the erector spinae muscle group and extend the length of the vertebral column. The surprisingly thick multifidi are directly accessible in the lumbar spine. They are the only muscles with fibers that lie across the posterior surface of the sacrum. and the shorter, smaller rotatories lie deep to the multifidi.
So to palpate the multifidi and the rotatories, I'm going to first isolate the lamina groove. So the lamina groove is that space that's in between the spinous processes and the transverse processes of the lumbar and thoracic vertebrae. And there you can see the vertebrae and that trough that's on either side of the spinous processes. Those are the lamina grooves. And that's where we're going to find the multifidi and the rotatories deep to the erectors. So let's just begin by getting a sense of where those landmarks are. Well, the spinous processes are pretty easy to find. They're usually running right up the center of the back. And there I can just easily feel a series of points that are the spinous processes. Here we can feel the thoracic spinous processes. I can even just roll my fingers around them on either side. There's little spaces in between them. And then as we move into the lumbar area, I notice that they're a little further apart as the vertebrae are larger. And I can follow them all the way down here to that surface of the sacrum. So we've got the spinous processes, and then we've got the transverse processes that are quite a bit more difficult to locate because they're deep. And the distance between the transverse processes is going to change because in the lumbar area, obviously the vertebrae are larger, so the TVPs are further lateral. But as we ascend the spine, the TVPs get closer to the spinous processes as the vertebrae get smaller in size. So let's first locate the lumbar TVPs. I'm going to just locate the spinous processes here and then slide over those large erector spinae muscles and then just kind of come in through the side door here laterally and feel for the bony ridge that's formed by the TVPs of the lumbar, right there. So I'm sort of going in that direction. And I'm in between the iliac crest and the 12th rib, and there's the TVPs right there. So I know that in that space is going to be the location of the rotatories and multifidi. So then I can follow that up, again, not working through the erectors, but just off to the side, and there we can continue to feel the TVPs as they lay next to the rib cage now, right there. So if I slide a little lateral, that's the surface of the ribs right there. But if I tuck in just a little bit here underneath and sort of going in the side door of the erectors, there's those TVPs of the thoracic vertebrae. And I can follow this all the way up here into that region between the scapula. So what we've done there is isolate where the lamina groove is, right in here. And now let's just take a moment to see those multifidi and rotatory. There they are as they sit right there in the lamina groove. And what I'm going to do is I'm going to set my fingers here, right in the thoracic area, and I'm just going to very slowly work my fingers through the erector fibers to get down to that level of the multifidi and the rotatories. Now, I might not feel specific bellies, but I'm definitely going to feel the density of this muscle tissue as it sits in the lamina groove, right in there. And if I work a little further inferior here, deep to the erectors, I'm going to really have to work my fingers in through those deep, thick erector fibers, but there, in that lamina groove, is the density and mass of those multifidi and rotatories. And finally, I can move all the way down to the surface of the sacrum here. I can work right through the sheet, and I can feel the muscle tissue that sits right on top of that. And that's got to be the multifidi because it's the only muscle that's found on the surface of the sacrum, right there.
All right. So moving away from the spine, pectoralis major is page 19. Page 19. Pectoralis major is huge, gigantic muscle on our chest. It is the most superficial muscle of our chest. It is on our clavicle, our sternum, our ribs, and our humerus. It's a very big muscle. So our origin is the medial clavicle, the sternum, and the ribs 1 through 6 costal cartilages. So the costal cartilage part, not the on the ribs, but the costal cartilage of the ribs. And then it comes all the way over into the bicipital groove of the humerus. Okay, so I have to write that down. I'm going to go up to the picture before for a minute. So this muscle comes over and creates the anterior fold of our axilla. So that is the anterior part of our armpit. Makes that front fold of our axilla right there. Okay, and you can see here, if you remember, rectus abdominis comes right up here, right? So the muscles come in, the fibers are going to come into each other right here. So rectus abdominis come down here. So pectoralis major and rectus abdominis are going to meet each other right here. And the action is it does adduction, horizontal adduction, medial rotation of the humerus. At the clavicular head, it does flexion of the humerus, and at the sternocostal head, it does extension of the humerus. Let me get my pen here. So this is the sternocostal head right here. And the clavicle, right? Sternocostal and clavicular, the clavicle, clavicular means clavicle, the head of the clavicle, right? Does flexion of the humerus. So horizontal adduction is one of my favorites. Okay, that's putting your arms out in front of you to do a hug. Hugging the hugger. Yeah, who doesn't like a good hug? sternocostal head. So at the sternum and the costals. So in this area. And that's going to be the clavicular head. Can I go back up to the first picture? The second picture? Sorry. Go back up to this one. Come in. Okay. All right. And everybody got the actions down? All right, perfect. Good. Let's see what some hugging looks like. Let's see where our horizontal adduction. There you go. All right, coming in for that great big bear hug right there. Oh yeah, good stuff. All right. And then we have, let's see. Medial rotation. So fade out that guy you can see right here. So medial rotation. So it's bringing the humerus into the midline of the body. Medial rotation. Do I have just an adduction? Let's see. Do we have a regular adduction? I think so. Ooh, so crazy. Okay. So pectoralis major, bringing the arm towards the body, adduction. So a little tiny bit, you can see that how the clavicle moves here, just slightly. So let's get our guy on here, pectoralis major.
The pectoralis major is a broad, powerful muscle located on the chest. Except for the part beneath breast tissue, its convergent, superficial fibers are accessible. Pectoralis major is divided into three segments: the clavicular, sternal, and costal fibers.
So my partner's supine on the table, and I'm going to begin by engaging the pectoralis major. So go ahead and make a gentle fist and just press it into your hip. There you go. And so he's adducting the shoulder joint. And there we can see a fabulous example of the pectoralis major, fully superficial on the top of the chest. Good. Go ahead and relax. So with that in mind, let's find some key bony landmarks that help isolate the pectoralis major. So first, I'll find the clavicle here, just on the top of the chest, and I'll isolate that medial portion, which leads to the top of the sternum, and I can follow all the way down the surface of the sternum to about the line of the nipple or beyond there. And that is going to be the medial outline edge of where the pectoralis major attaches. And then I can follow those convergent fibers laterally to where they tuck underneath the deltoid and attach here on the anterior surface of the humerus at the crest of the greater tubercle of the humerus. Now, this isn't going to be a bony landmark that you can readily isolate. It's a little difficult at first, but it's nice to know its general location here on the anterior surface of the humerus. Good. So now let's go ahead and engage the muscle again. Super. And so here we can see that outline of the muscle. There's the inferior edge. There's that superior edge, that deltopectoral groove that separates the pectoralis major from the anterior deltoid. And we can also even see some of those fibers converge that way. Good. Go ahead and relax. So now, with that in mind, I can reach in and really grasp a lot of this tissue. That's the pectoralis major. Really lift this up off the rib cage. And it gets much thinner as you move medially toward the sternum. And as those fibers converge, it gets quite thicker here as it passes just beside the deltoid. Good. Now, if I wanted to shorten or lengthen the pec major, I can just abduct the shoulder up over the head, and all of these fibers lengthen. And then to shorten the pectoralis major, I can just bring the arm forward into flexion and adduction, and all of those fibers become very shortened. Good. Go ahead and relax. Now, that was relatively straightforward since my partner was a male. But the question arises, when palpating on a female, how do you access the pectoralis major and other muscles of the chest and axilla without contacting breast tissue? Well, let's show you how. So the first thing I'm going to do is just communicate my intentions to my partner. So Lynn, I'd like to access the pectoralis major. It's a muscle of the chest. Would that be all right with you?
Yes.
Okay. And if at any time you get uncomfortable or you want to stop, you just let me know. Mm-hmm. Okay. So my partner's in a supine position, which oftentimes the breast shifts laterally, which makes it much easier to access this sternal area in between the breasts, right here, as well as the upper pectoral region underneath the clavicle here. But oftentimes in a supine position, large breasts will shift laterally and crowd the axilla. Well, we have two options. First, I can ask my partner, Lynn, would you be willing to just shift your breast medially away from the axilla? There we go, like so. And then I can position the arm and open up the axilla and access some of this tissue right here much more easily. Pectoralis major, pectoralis minor. The other thing I can do is I can just use the back of my hand like so to shift breast tissue out of the way and again access into the axilla. So those are just two things that you can do here with your partner supine. So in a sideline position, breast tissue often falls down toward the table away from the axilla, and by just shifting the arm and scapula forward allows for much easier access of the axilla, and the breast tissue is completely out of the way.
Okay. I am not finding. Somebody asked me if I could find an illustration of the extension of the humerus at the sternocostal head, and I'm not finding any really good pictures of this. So, no, I'm not finding any ones, but you guys can, do a deep dive on your own. But it is 8 o'clock, and I think that everybody is probably ready for another break. So let's do another tenor. So 8, 10. I'll see you in a few. All right, we're back. Okay, so we're gonna look at the next two together. We're gonna go with pectoralis minor first, and that is on page 18. Pectoralis minor is deep to pectoralis major. It is on ribs 3, 4, and 5, and it's actually on the ribs, not the costal cartilages. And it comes over onto the coracoid process. So, that being said, what bone do you think this one moves? If pectoralis major goes onto the humerus and pectoralis minor goes onto the coracoid process of the scapula, what bone do you think this one moves? Pectoralis major moves. Amazing. Good job. It moves the scapula, coracoid process of the scapula. So pectoralis minor is going to move the scapula, while pectoralis major moves the humerus. Makes sense? So, as in our little video demonstration, these both are underlying to breast tissue. So when you work in these areas, you need to be very respectful to the people you're working with and ask permission to work in these two areas, on these two muscles, okay? Very much so have to ask permission. So pectoralis minor. Anterior ribs origin, anterior ribs 3, 4, and 5. And the insertion is the coracoid process of the scapula. So the coracoid process of the scapula is our most anterior part of our scapula. Okay. And if you haven't felt this coracoid process before, if you put your hand under your clavicle right at your shoulder and roll your shoulder forward, you're going to feel a little bone that protrudes right out onto your fingertips. And that little bone you feel is your coracoid process. So our actions, it's a fun picture. Our actions are abduction, depression, medial rotation of the scapula. And just like the scalenes, you can see the scalenes in this picture, that nerve, the brachial plexus nerve and the brachial vein and artery come down and come underneath the pectoralis minor. So this muscle could interfere with that nerve, with some nerves and some arteries and veins. So you have to be careful when working with this muscle. You have to check in and make sure that you're not impinging the nerve. You have to ask, you know, how are you feeling? Make sure nobody has like tingling or numbness. Because if they do, then you need to reposition yourself so that you're not pinching off any of the nerves or the arteries in this area. Oh, what page is this? Page 18. So medial rotation, so it says downward of the scapula. So remember before we talked about the scapula, we were talking about rotation. Again, we're talking about the inferior angle, which way the inferior angle of the scapula is going to go when we're looking at medial rotation. So serratus anterior, we talked about serratus anterior, and pectoralis minor are synergists. So they work together. Okay, let me get onto this. Yeah, over here, let's see. So there's pec major right there. Let's see if I can fade this guy out here. So that's doing some shoulder extension. It's not really doing too much. It's moving the scapula a little bit, right? Let's see. Abduction. Oh, see, it didn't even show you. Abduction, it doesn't even show you it here. That's funny. My program. My program. I wonder if it has it in the front here. Probably not. Nope. Okay. So it's not really showing you on the pectoralis minor there. You get some in the rib elevation. Here. So here, let me back this out a little bit. So it's on the ribs 3, 4, 5. It's on the coracoid process right there, so you can see. And remember how I said, oops, we're looking at where this goes. Zoom that way. Okay. All right. let's get rid of this. Erase all drawings. And this program does not show me the next muscle in an action besides. There. Can I see it here? Oh, I can. Okay. So this one doesn't move, but here's pectoralis minor. All right. So you can see it coming up on the ribs and coming over. And this is our next muscle, subclavius. So it's sub for under, below the clavicle. So you can see it right there, under the clavicle. All right, so that's our next muscle that we're going to go over. Oh, what? I guess I don't even have a picture of it. How funny, but it's on page 18. So in your book, on page 18, you have subclavius, and you need to know the origin. So we'll put it back there. You need to know the origin is the first rib, costal cartilage junction. You need to know the insertion is the inferior shaft of the clavicle, the middle third. And it depresses, the action is depresses the clavicle and stabilizes the sternoclavicular joint. What muscle is this? This is subclavius. It is also on page 18. It's down underneath the pectoralis minor. Can I type it? Can you see the origin and the insertion one more time, please? Sure. Yep. Hold on. Okay. So, Carlos, if you can see my cursor, subclavius is right there. That's the name, subclavius. All right. And the origin is the first rib costal cartilage junction. So origin is the first rib costal cartilage junction, which is right here. The insertion is the inferior shaft of the clavicle, the middle third. So the inferior shaft Can I write it to you guys? Do you guys not have your book? It's all written in your book. depresses the clavicle and stabilizes the sternoclavicular, nice R, joint. Okay. Costal cartilage, I'm losing it. Junction. Okay. Now you guys can take a picture. Okay. All right. For those of you who need to take the picture, go ahead and take the picture. Okay. So our sternoclavicular sternum, our sternum and our clavicle meet together. They, what we call, articulate. So they talk to each other, they move with each other to make a joint. So that's the sternoclavicular joint right there. So that's where it's going to stabilize that joint. Okay, and it's inferior, so it's on the underside of the clavicle. Okay, everybody got this? Because I'm going to erase it. Going once, going twice. Everybody good? Done. All right, let's watch our video on pectoralis minor.
The pectoralis minor lies next to the rib cage deep to the pectoralis major. Its fibers run perpendicular to the pectoralis major fibers from the scapula's coracoid process to the upper ribs. The major vessels serving the arm, the brachial plexus, axillary artery and vein, cross underneath the pectoralis minor, creating the potential for neurovascular compression by this muscle.
So let's begin by isolating a few of the key bony landmarks that really point out where the pectoralis minor is located. The first is going to be the coracoid process of the scapula, which I can easily find by locating that lateral portion of the clavicle there, and then just sliding inferior and using my broad finger pads right here. It's sort of like a little fingertip that points out right there. And that's where the pectoralis minor is going to attach and then run diagonally across the chest. And there we can see it just deep to the pectoralis major. Great. So we've got the coracoid process, and then it comes down and attaches to the third, fourth, and fifth ribs. Well, there's a lot of ribs, so how do we know which one's the third, fourth, and fifth? Here's how. I'm going to just locate the top of my partner's sternum right here, that manubrium, and then I'm going to just work my fingers down and about, right there, about an inch, inch and a half down, there's a little speed bump in between the body of the manubrium and the sternum. And if I walk my fingers laterally a little bit, there's a rib right there. Well, right off that sternal notch, that little hump, is going to be the second rib. So if I know that this is the second rib, there's a little gap. That means this is the third rib, and there's a little gap. And there's the fourth rib, and a little gap, and there's the fifth rib. So we've got the fifth, fourth, and third rib right there. And if I just kind of walk my fingers laterally a little bit, I can just imagine that that, again, as we see it, is where the pectoralis minor is going to attach. So now that I have an idea of where the pectoralis minor is located, the question is, how am I going to access it? Well, I could just work right through the pectoralis major fibers here, but the pec major is pretty thick muscle. So instead, I'm going to go in through the side door of the axilla. So for that, I'm just going to passively abduct my partner's arm, and I'm going to locate that lateral edge of the pectoralis major right there. And if I'm not quite sure, go ahead and make a little fist and press it into your hip. Well, there we can really locate that lateral edge. So I'm going to set my thumb just in the axilla beneath that, and there's the surface of the ribs right there. And I'm going to very slowly, with my partner's breath, sink my thumb up into the pathway of where that pectoralis minor is going to be, right in there. And I feel the density of a small muscle that lays right next to the rib cage. And go ahead and just bring your shoulder down toward your hip. Great. And as he does so, a very small contraction, underneath my thumb, I can feel that pectoralis minor engaging. Good. Go ahead and relax. And sure enough, there that muscle softens. And I can also scoop the elbow and just mobilize the shoulder a little bit to even shorten up some of this axilla and pec major tissue to work my thumb even a little deeper. And I'm working nice and softly and gently right in there. Good. Before I turn my partner sideline, to lengthen the pectoralis minor, I can scoop the shoulder and shrug the shoulder up and sort of round the scapula this way. And to shorten it, I can depress the scapula and bring the shoulder forward like so. So bringing these two attachments closer together, or to lengthen them further apart. So now with my partner sideline, I'm going to just scoop the elbow and bring the arm and the scapula around the thorax like so. And what's great about this is it really opens up the axilla to access part of the pec minor. So I'm going to set my thumb right there along the side of the rib cage and just slowly descend right into that pathway of the pec minor. Nice and soft and slowly. And if I ask my partner, go ahead and try to bring your shoulder down toward your hip so he depresses his scapula. There I can feel the edge of the pectoralis minor right along the rib cage. Engage. Great, and relax. Good. And so another great way that you can access the pectoralis minor in a sideline position by getting your hands right in there in the axilla.
Okay. So last set of muscles for tonight is page 26. The deltoids are also a group of muscles. They're also one of my faves because of the action. One of the many actions that they do. They do a lot of actions for us. They cover the shoulder joint, and they come right down onto this little tiny point on our humerus called the deltoid tuberosity. They're on our clavicle and our scapula. So they are quite the muscle. The origin is the spine of the scapula, the acromion, and the lateral clavicle. So it says sac underneath there, so you could use sac to help you remember scapula, acromion, clavicle. And then the insertion is the deltoid tuberosity of the humerus. Okay. The actions, lots of actions. So the anterior deltoid does flexion, horizontal adduction, and medial rotation of the humerus. The middle deltoid does abduction of the humerus to 90 degrees. The posterior deltoid does extension, horizontal abduction, and lateral rotation of the humerus. So we have an anterior, a middle, and a posterior deltoid. I'm gonna give you guys a minute to write that down. It's a lot. I don't think it's gonna fit in that little square. So who can remember what other muscle did the horizontal adduction of the humerus? My favorite thing. Yeah, good job. Pectoralis major. So this works with pectoralis major to help you hug. Nice. You guys are doing great. I know, it's been a lot of muscles tonight. So it's one of those hugging muscles. So, but this muscle only does adduction in the horizontal adduction. It does not bring your arms back to your body, to the midline of your body, like from your hands straight down. It does. It moves our arms in a lot of directions, but it cannot like bring your arms straight and tuck them tight into your body. It's the one move it cannot do. Okay, did everybody get all these actions down? Yes, perfect. All right. Let's go back to actions. See this bad boy work. Okay. You can see right there. Flexion. Sure. Deltoids. So flexion. Bringing the arm straight out in front of you. Flexion. You see pectoralis major here. Doing the same action here. Okay. Extension. Here's your deltoids. Bringing the arm behind you. So behind you, extension. Pectoralis minor helping out in that one. Systemus dorsi helping out in that one. horizontal abduction. Teres minor, working out with this set of deltoids. Okay. Bring it in for the big bear hug. Oh, that was taking it away out of the bear hug. Sorry. This is bringing it in for the bear hug. The last picture was taken out. Corcobrachialis is helping it bring in. Corcobrachialis is on my list too. Pec major, corcobrachialis, and the deltoids. Hugging. Okay. Shoulder abduction. So this is to the 90 degree. That's the 90 degree that they're talking about. Because if you look right here, this is the spine of the scapula, right? You can't bring this muscle up over the bone where it has its attachment. So it can only go that far. And then medial rotation. And then it shows you lateral rotation. So if you go medial, you got to be able to do lateral. Right? You got to be able to come back. So this muscle does both medial and lateral rotation. Like I said, it does a lot of stuff for us, a lot of movement in our arm. Okay, so let's watch our fun guy do the deltoids.
The triangular-shaped deltoid is located on the cap of the shoulder. The origin of the deltoid, which is interestingly enough identical to the insertion of the trapezius, curves around the spine of the scapula and clavicle, forming a V shape. And from this broad origin, the fibers converge down the arm to attach at the deltoid tuberosity.
The deltoid's a great muscle to start with because it's totally accessible right here on the cap of the shoulder. So I could do this supine or prone or side lying, but I like seated because you can really access all sides of the muscle. So let's begin by seeing this muscle engage. I'm just going to ask my partner to go ahead and try to abduct your arm against my resistance. Oh, that's great. And there we see a fabulous example of the deltoid. Here's that posterior edge, and there we can see that anterior edge there. And you really get a sense of the convergent fibers all funneling down to that deltoid tuberosity. Good. Go ahead and relax. Now let's locate some of the landmarks that really isolate where the deltoid is. First, I'm going to find this attachment here at the top of the shoulder, where they sort of form a V here at the top. And the first side of that is going to be the spine of the scapula. This is that superficial ridge of bone that sort of runs up to the top of the shoulder. And notice I'm not poking him with my finger. No, I'm just using a nice set of broad finger pads to really differentiate the edge of that bone. And then it ends right here at the acromion, at the top of the shoulder. And then the deltoid's attachment continues here onto that lateral portion of the clavicle. And again, there's that shape of that attachment. Then all of those fibers come down and attach at that deltoid tuberosity. And if you ever get confused of exactly where the deltoid tuberosity is, you can divide the arm in half. Pretty much right there at the halfway point is where that sort of small, subtle sort of mound of bone on the side of the humerus is located. And that's the other attachment for the deltoid. Great. So now that I know that all of this is the deltoid and it's completely superficial, I can just get my fingers on it here, just grasp it and lift it up off the arm. There we go. And you can really roll your fingers across its fibers and follow them again right down as they converge at the tuberosity. Good. Now, let's just take a moment to differentiate a few things. I'm going to ask my partner to just go ahead and try to flex your arm that way and a little bit out to the side. Great. And there we can see the line that divides the deltoid from the pectoralis major. That's called your deltopectoral groove. And so here we've got those anterior fibers of the deltoid, and there we have the pectoralis major. Good. Here we have the edge of the biceps brachii. There we can even see some of the triceps. Great. And relax. Because the deltoid is an antagonist to itself, here's a fun little thing you can do. I'm just going to ask my partner to just go ahead and try to flex his shoulder. So he's going to try to swing his arm that way. Great. So flexion engages these, the anterior fibers of the deltoid, and they're clearly engaged. But the posterior fibers back here are totally relaxed. They're not doing anything. And now conversely, if I ask him to go ahead and try to extend at the shoulder, there we go. Well, now the posterior fibers are contracting, but the anterior fibers are not doing anything. So it's just a fun way you can see how the deltoid, being a convergent muscle, is really an antagonist to itself, and how when one part of it engages, the other part has to relax. And finally, if I wanted to shorten the anterior fibers of the deltoid, I can passively flex the shoulder like so, even medially rotated, which conversely lengthens the posterior fibers. And if I want to shorten the posterior fibers, I can extend the shoulder, which then, of course, lengthens the anterior fibers. And if I wanted to shorten the entire deltoid, I can passively abduct the shoulder, and then to lengthen it, of course, I can adduct the shoulder.
Hey, awesome. Sit. We're done with our structure. Yay, done with the structure. Perfect. So we need to do review. Review. So let's get out of this. Let's get ready to answer some questions. You guys ready? Give me 5 examples of blood vessels. Nice. Good. Good. I know it's taking a minute for you guys to type. It's all right. Arteries, arterioles, capillaries, venules, and veins are all types of blood vessels. So great job. Excuse me. Great job. Great job. Blood always returns to the heart in a what? You guys are rocking. Doing so good. Yeah. Yeah. Oh, it's yellow. Let me go back to this. One more. To this. Are you good with this one? Yes. Okay. So blood always returns to the heart in a vein. Blood always returns to the heart in a vein. So great job, you guys. It is yellow. Yellow means it's mellow. So you should write it down. Venous blood return is strictly aided by backflow valves. Venous meaning veins, right? Blood return is strictly aided by backflow valves. So remember that veins have backflow valves. Write yourself a note. Because our blood needs to keep moving in one direction and not pull and come back. Okay. Oops, wrong way. Blood always leaves the heart in a, good job. I don't know how you guys type so fast. Good job. Blood always leaves the heart in an artery. A for away. Away. Blood always leaves the heart in an artery. Look at all these arches. Femoral, popliteal, anterior tibial, posterior tibial, peroneal, dorsal pedius, and then we have a arch. It's interesting. Just remember, blood always leaves the heart in an artery. Oxygen, carbonation, oxygen, carbon dioxide, and nutrients are exchanged in what blood vessel? Good job. Good. Oxygen, carbon dioxide, and nutrients are exchanged in the capillaries. Yes, or better, the capillary beds, right? Capillaries. We don't want to know the vessel, so the vessel is the capillary. The structural differences between veins and arteries. What's the structural difference between a vein and an artery? Good. Both of those answers are great. Yep. Isaac, I don't think that counts. Structural differences. Perfect. Yes. Yes, you guys are on the mark. So arteries are from the heart to the rest of the body. They carry most oxygenated blood. Excuse me. They have high pressure with thicker walls, no valves, and the blood speed is fast. Veins are from the rest of the body to the heart. They carry mostly deoxygenated blood, the lower pressure with thinner walls. They have valves and the blood speed is low or slow. So great job, great job. So thinner or thicker walls. One carries oxygenated blood or the other carries deoxygenated blood. Yeah, you guys did amazing. What is the difference between an embolism and a thrombosis? Good. Good. The difference between an embolus and a thrombosis is that the thrombosis is a lodged clot and an embolus is a moving clot. So I'll give you guys a second to write this one down because I know you guys don't have notes on this one. So a thrombosis is contraindicated to massage over because we don't want it to become an embolus and be a moving clot. Okay. Hard, lumpy, discolored superficial veins are a contraindication for local massage. Does anybody remember a different name, a technical name for hard, lumpy, discolored superficial veins? Yes, very good. Varicose veins. Yes. Good job. Blood enters into which chamber of the heart first? Chamber. Which chamber? So some of you got it. Most of you got it. It's going to be the right atrium. The blood enters into the right atrium first. The right atrium. Which chamber does it enter next? Most of you have it. It goes to the right ventricle. So it's from the right atrium to the right ventricle. The name of the blood vessel leaving the second chamber of the heart. So the second chamber of the heart is the one we were just talking about, right? So what leaves that chamber? You guys are doing amazing. going to be the pulmonary artery. So we're sending it off, sending the blood off to the through the pulmonary artery to the lungs. Where is the blood when it leaves the second chamber? Let me just have that. Well, yeah, I guess I just answered that for you. So it goes out the artery to where? To the lungs. I just told you guys. It goes to the lungs. I'm guessing you guys need another break. I think you guys need another little break. Is that a true statement? Yes. Yes. Okay. Please. 9:20. Alrighty. Let's get back to it. Review. Why does blood go to the lungs? Good. Awesome. Good. Yeah. To become oxygenated. Blood goes to the lungs to become oxygenated. Good job. Blood re-enters the heart into which chamber? Mm-hmm. Well, we're looking for a chamber, so it would have to be not a vein at this point, right? So the blood re-enters the heart into the left atrium. Good job. Remember, atrium or entry hall. What is the biggest chamber of the heart? Chamber. I want a chamber. And we already had the right and left atrium. We already had the right ventricle. So if I'm looking for the last chamber, good. It's going to be the left ventricle. Because the left atrium goes into the left ventricle, which is the biggest of all the chambers. Why is the left ventricle the biggest chamber of the heart? Those are great answers, you guys. It's the biggest chamber because it has to push all the blood through the aortic valve into your body. Right? It has to be able to push the blood through the valve into the body. So that takes a big area to be able to push all that through that tube, push it out. No. When you exhale, is the diaphragm relaxed or contracted? You guys are 50-50 on this one. It's pretty funny. You got a 50-50 chance, right? The diaphragm is relaxed when you exhale, forcing the air out of your lungs. So we need to get all the air out of our lungs for the best exchange. Intercostals are the muscles most important to massage and assisting respiratory function. So our intercostals really help open our rib cage so that we can get a nice big breath. So massaging the intercostals really helps people with breathing problems. Haha, open your poles. Next one's going to be a poll. So answer in the polls on the next one. What substance is the blood carries oxygen to other cells of the body? What substance in the blood carries oxygen to other cells of the body? Good. I'm going to close the poll. Share your answer. Most of you guys picked hemoglobin, which is correct. And yellow, hemoglobin carries oxygen to other cells in the body. Hardening of the arteries due to a buildup of plaque made of cholesterol and lipids is called job. Closing the poll. Most of you guys picked arteriosclerosis, which indeed is the answer. Arteriosclerosis is narrowing of the arteries. The mitral valve is also known as the Get ready to close the poll. Majority picked bicuspid, and you'd be right. It is the bicuspid valve, which they call the mitral valve because it's shaped like that hat that the Catholic priests, some Catholic priests wear. The mitre hat. During quiet inspiration, which muscles are being contracted? During quiet. Very good. Getting ready to close the poll. Share the results. Majority of you guys picked the diaphragm and the external intercostals, so quiet inspiration. So the scalenes are the scary inspiration, right? So that's not so quiet. Isn't quiet. But taking a nice deep breath in can be quiet. You didn't even hear me take a deep breath in. Okay. The heart has blank chambers. The uppermost are called what? Getting ready to close the poll. I'm going to share. Majority picked 4 in atria, and you would be right. There are 4 chambers of the heart, and the upper 2 are called the atria. So 2-part question. 4 chambers, and the upper 2 are atria. The fluid portion of blood is called and getting ready to close the poll. Share the poll. Majority of you guys picked plasma, which is correct. Plasma. That's what we call the fluid portion of blood, plasma. Which is exchanged in the pulmonary capillary beds? In the pulmonary capillary beds, what is exchanged? I'm going to close the poll. Majority of you guys put nutrients and gases, but no, nutrients are not exchanged in the lungs. Only gases are exchanged in the lungs. So in the lungs, it's only gases. It's CO2 for O2. Another term for red blood cell is I'm getting ready to close the bowl. Majority of you picked erythrocyte, and you would be correct, Mundo. Erythrocyte is the technical term for a blood cell. Blood is a blank tissue. Wow, I'm going to close this poll because you guys are on fire. And you guys all picked, every one of you picked connective tissue, and you're correct. So that's amazing. Good job. Perfect. A plus plus plus. Oxygenated blood returning from the lungs enters the okay, I'm getting ready to close the poll. Majority picked left atrium, and you are correct. Oxygenated blood returning from the lungs comes into the left atrium. It is only at the blank level that exchanges between blood and tissue cell occur. Okay, I'm getting ready to close the poll. Majority of you picked capillary, and you are right. I really like this picture to show you the exchanges that are happening in the capillary. So oxygen and nutrients, carbon dioxide and waste. And then it really shows a good color change here from oxygenated to deoxygenated blood. That's a great picture. Which best describes pulmonary circulation? Okay, one of these got cut off. So, give you a big hint. It's probably the one that got cut off because it's so long. Okay, I'm going to close the poll. Okay, it's the one that got cut off. So it is the right atrium to the right ventricle to the lungs via the pulmonary artery to the pulmonary vein to the left side of the heart. It was so big, I couldn't get it all the way in the poll. So, which describes pulmonary circulation best? Right atrium, right ventricle, lungs via the pulmonary artery, pulmonary vein to the left side of the heart. Homeopoiesis, blood cell formation takes place in closing the poll. Most of you guys picked red bone marrow, which is, for the win, the answer. Homeopoiesis, blood cell formation takes place in the red bone marrow. What is ischemia? Getting ready to close the pole. Closing the pole. Decrease blood flow to the tissue. Majority is right. Ischemia is decreased blood flow to the tissue. Inflammation of the sac that surrounds the heart is called getting ready to close the pole. Pericarditis, which is the answer. That's what everybody picked. Majority. Pericarditis is the inflammation of the sac around the heart. Pericardium is the sac. And is an inflammation. ITS. ITIS is inflammation. Emphysema is a term used to describe closing the pole. Destruction of the alveoli in the lungs, majority. You guys pick that one. That's what it is. Emphysema really destroys these little air sacs in our lungs. Which of the following describes cell death, cell or tissue death? Getting ready to close the poll. Close the poll. Necrosis. Necrosis. Necrosis is cell or tissue death. Necrosis. You might have heard it. It's necrotic. It's another way to say that. It's necrotic. It's dying. Necrosis is death. Small sacs in the lungs that fill with air are the getting ready to close the poll. Closing the poll. Okay. So most of you picked, majority of you picked alveoli. Some of you picked bronchioles. Alveoli is the correct answer. Bronchioles are the branches that the alveoli are on. If that helps you guys. Alveoli are the sacs. Bronchioles are the tubes. What is the primary effect of massage on the cardiovascular system? A bronchi is one bronchial tube. It's singular. So this is our last one. So getting ready to close the poll. Majority of you picked dilate the blood vessels. And the primary effect of massage on the cardiovascular system is to increase muscle size. Good to know. So that was the last poll, and it is time to go. So have a great evening. Thank you. I will not see you Sunday. But those of you who I will see before that, I will see you then. And I will see you again Wednesday. So go ahead and log yourself out for class. Goodbye, you're welcome. Oh, what happened to Dan? Dan and I just split the class. So he did 5 and I'm doing 5. Good night. Make sure to log yourself off. Did I get your new midterm score? I didn't even know to look. Let me look. I'm looking, hold on. It's not as quick as one would hope. ER. Well, very good. Nice job. I will make sure I change that on the books. Great job. Give yourself a big pat on the back for that one, okay? All right. I'll see you later. Good night.